Good afternoon, ladies and gentlemen, and welcome to the Lake Superior Quality Innovation Network, Strategies for Self-Management in Patients with Diabetes webinar. Your host, Elise DeYoung, will now begin.
Thank you so much, and thank you everyone for joining us this afternoon. This webinar is a collaboration between Michigan Community Health Worker Alliance and Lake Superior Quality Innovation Network. So today we are going to be going over a couple things. The first, just discussing the diabetes education programs in Michigan. So the Diabetes Prevention Programming, or DPP, Diabetes Personal Action Towards Health, or DPAS, and Diabetes Self-Management Education and Support, or DSME. We'll also discuss how diabetes education benefits participants in the management of their chronic conditions, specifically diabetes. Also how you or your organization can get more involved in diabetes education. And then lastly, Mark Lausch will be discussing motivational interviewing concepts and how to use motivational interviewing with patients with diabetes. So the Diabetes Prevention Program is a CDC-recognized lifestyle change program, and this just means that there'll be a trained leader leading the group and using a CDC-approved curriculum. So this trained leader typically facilitates a small group of adults, and this will be either in person or online. And this group setting really allows participants to be in a group of people with similar goals, similar challenges, and be able to share their experiences in a really supportive environment. And this program consists of 25 one-hour sessions delivered over the course of a year. So the first 6 months, the group would be meeting weekly, and then the last 6 months, the group would be meeting twice a month. So eligibility for DPP, participants must be adults, overweight, no previous diagnosis of type 1 or type 2 diabetes, although they can be diagnosed with gestational diabetes in the past, and then having one of the following blood test results within a prediabetes range within the past year, as shown below. So this is just kind of a snapshot of those blood test results. It's a decision pathway for those results and then leading to either if the patient has diabetes or prediabetes. So this just kind of shows you a more visual concept of that. So for the DPP curriculum, participants are going to learn to discuss a multitude of topics. So eating healthy without giving up all the foods you love, really finding that medium and being able to use moderation in maybe higher calorie foods while still balancing with healthier meals. Being able to add physical activity to your life, really problem solving how to fit physical activity into a busy schedule, or even finding physical activity that works best for you, something that you enjoy and isn't so much of a chore. Being able to deal with stress, coping with challenges that could get you off track. So how to choose healthy food if you're eating out a lot during the week, especially for work or you're really busy. How to fit in physical activity even 5 minutes at a time when you're really busy with your kids or with work. Being able to get back on track. So life happens. Being able to really recognize that you're off track and how to get back on it to get towards your goals. And then the second half of the program really focuses on maintenance. So being able to use what you've learned in those first 6 months and apply them to maintaining the changes that you've made. So these sessions review key ideas like tracking food, tracking your physical activity, setting goals, how to stay motivated, and how to overcome day-to-day barriers. So then we're going to transition into Diabetes Personal Action Towards Health, or Diabetes PATH. And the Diabetes PATH curriculum was developed by Stanford University, and it's a licensed program. And this is going to be a structured 6-week workshop series that's about 2.5 hours per week. And this is led by 2 certified leaders. Typically, there are about 10 to 15 participants in the workshop, so it's a little bit bigger of a group, but still has that peer support and still has that participative structure. So the leaders really facilitate the conversation and guide the group through the topics of the workshop, but it's really the participants who are going to be having those discussions, again, sharing their experiences and learning from one another. And just one more thing to mention about all these programs is they are evidence-based, so they have demonstrated results and we've seen really great progress with everybody who's participated in these programs. So eligibility for Diabetes Pass is really geared towards those with type 2 diabetes, but also a huge focus on bringing family, friends, and caregivers with you, because you're not going through diabetes alone. There are other people who are affected by it and who can really support you. And this is typically free or low cost for Diabetes Pass. So the Diabetes Pass curriculum, again, really focuses on a wide range of topics. And really what Diabetes Pass focuses on is helping individuals with type 2 diabetes and their caregivers manage their condition. So subjects cover things like appropriate exercise for maintaining and improving strength and endurance, how to even use exercise to maintain your weight, or even if you have weight loss, how to incorporate that into your life. Healthy eating, so participants learn the guidelines for healthy eating, and then they use those guidelines to plan a healthy meal for someone with diabetes, and are able to really take that outside of the workshop and apply that to their life. They also talk about reading food labels, really what to look for in terms of calorie content, sugar content, sodium, things like that, and then again, how to practice reading food labels outside of the workshop. They discuss the appropriate use of medication. They discuss the techniques to deal with symptoms of diabetes like fatigue, pain, having hyperglycemia or hypoglycemia, how to deal with stress and emotional problems, how to deal with depression, anger, fear, frustration, all the things that can be related to having a complicated condition and many chronic conditions. And then lastly, they discuss working with their healthcare provider and really becoming partners in the management of diabetes and becoming less passive but more active in their care. So the workshop covers many topics about chronic conditions and diabetes, but what participants really are going to learn are ways to help take care of their health. So there are different techniques used throughout the workshop to help patients become better self-managers. So for the goal setting and action planning concepts, participants really learn how to make weekly action plans to get towards smaller goals or even greater goals, and that also helps them stay on track with their diabetes care. For the feedback and problem solving, during the week, each patient brings back their weekly action plan. They share their experiences, their successes, as well as help each other problem solve any problems they may encounter related to managing their diabetes. The leaders also take a huge part in this and help give that feedback. So if they want to take on that action plan again for the following week, they can do that with those adjustments made in class. The decision-making, participants actually use a decision-making tool to identify a decision that may need to be made. They outline pros and cons of each option. They score the pros and cons based on level of importance. And then they make a decision based on that score and based on the gut test. So if the score says one thing, but the gut says another, and you feel it in your gut that it's not right, then ultimately they're encouraged to go with their gut in terms of that decision. And then lastly, for the management tool, participants are presented with a toolbox at the beginning of the workshop. And this toolbox has different management tool techniques to help them manage their conditions. So some of these include healthy eating, working with a healthcare provider, physical activity, managing stress, meditation, and they're able to use these tools from the toolbox and practice them within the workshop and then use them outside the workshop again to just really manage their care and their diabetes. So this just gives a snapshot overview of the workshop and what's covered each week. This is something that we have personally given to participants. We've also given to sites that host the workshop just to show in kind of a shorter version of what we'll be talking about through the 6 weeks. So now we're going to transition to the Diabetes Self-Management Education and Support, or DSME. So this is a little bit different from the others and kind of outlined here. It's a covered Medicaid and Medicare benefit when providing in a hospital-based program. And beneficiaries are eligible for 10 hours within the first year of diagnosis and up to 2 hours per year after the first year. This also occurs in a smaller setting, typically one-on-one, but can also be in a small group, and it'll be in a clinical-based environment, such as a hospital outpatient department and clinics. This will be taught by a licensed healthcare provider, such as a certified diabetes educator, registered nurse, registered dietitian, or a licensed registered pharmacist. So a community health worker can be part of the team, but they would be co-leading with the licensed healthcare provider. And DSMEs does not have as specific of a curriculum, but it needs to align with the 10 DSME standards and covers things like diabetes, information on diabetes and treatment options, healthy eating, physical activity, medication usage, monitoring blood glucose levels, preventing and detecting and actually treating acute and chronic complications, and again, kind of coping with difficult emotions and stress, and problem solving is also involved in the DSME program. So in terms of eligibility for DSMEs, this will be for people with diabetes that are either newly diagnosed, have had a change in treatment or condition, or have never received comprehensive diabetes self-management education. And the important part to note is that it must be ordered by a physician or qualified non-physician practitioner in order to be covered. So to get involved in either of these programs, the first thing I want to highlight is myhealthyprograms.org, and that's myhealthyprograms.org. It was developed to promote evidence-based self-management programs and physical activity programs that are available in Michigan communities. So you can go on myhealthyprograms.org. You can find more information on GPP, DPAP, and DSMEs, as well as other programs that you see up on the PowerPoint. And this also will show you different classes that are in the area, as well as the information to the program. If you are interested in training to become a certified leader for any of the programs, there are different ways to do that. So for diabetes prevention programming, eligible lifestyle coaches must have been formally trained to CDC-approved curriculum by one of the following ways. So either through a training entity listed on the CDC website, it can be through a private organization within the national network of CDC-recognized program sites. It can be through a virtual organization, which is CDC-recognized, or you can become trained by a master trainer. So I've included the website for a list of lifestyle coach and master training organizations that you can do it through. For diabetes PAP, Mark, who will be presenting later, is actually a master trainer in diabetes PAP. So I've included his email. If this is something you're interested in becoming trained, we can connect you with other leader trainings, or if we happen to be hosting one here, we can invite you to a hosted training by ourselves. And then lastly, for DSMEs, like I said, it's a licensed healthcare provider who would be leading these, and it would have to be at a certified program, so either ADA recognition or AADE accreditation. And just something to note that MDHHS Diabetes Prevention and Control Program, in partnership with Michigan Medicaid, has a certification program for hospital-based DSMEs. So in addition to the ADA recognition and AADE accreditation, these programs receive additional support from MDHHS to ensure program quality and alignment with those 10 DSME standards that I've mentioned a couple slides ago. So I've included a list of programs at the bottom, the michigan.gov/diabetes. And again, for DSMEs, it would be a licensed healthcare provider at these certified programs, but MDHHS has a certification program as well. So with that, I'm going to turn it over to Mark to talk about motivational interviewing.
Thanks, Elise. Hey, good afternoon, everyone. My name is Mark Losh, and I'm a licensed master social worker in the state of Michigan, licensed in Michigan. And yeah, both Elise and I are leaders, are diabetes personal action toward health leaders, and as Elise mentioned, I'm a master trainer too. And we have a lot of fun doing the diabetes personal action toward health workshop in the community. We often focus our attention on physician practices and do them in physician offices, but we've also in the past done them in senior high-rises in Detroit, and we just have a good time doing it. It's a great way to connect with Medicare beneficiaries and get the message about diabetes and the changes that patients can make, the small changes that they can make to improve their health. But I'm here today to talk a little bit about motivational interviewing. And now, just to preface this, I am not a motivational interviewing expert. What I'm going to provide you today are some basic sort of the principles, the 5 principles of motivational interviewing, and some tips and strategies that can allow you to have instant influence on patients. I like that term, instant influence, and I didn't come up with that. I heard someone else use that one time as a way to kind of frame their experience using motivational interviewing strategies and techniques, and kind of having an influence on patients by just meeting them where they're at. And we're going to talk about that in just a second. So, no, I'm not a motivational interviewing expert, but I do use motivational interviewing techniques in some of our training programs and other things, and I have used it in clinical practice. I came kind of late in my career. I've been a social worker for almost 30 years, and I kind of came in late, or motivational interviewing came into my life late in my clinical career. And because in the past, the way that I was trained and the way a lot of healthcare professionals were, we took the theory or the premise that the patient was the patient, and we were the expert, and we would kind of tell the patient what to do, and they would follow that advice and kind of get better. And motivation interviewing changes the paradigm a bit and changes this to put the patient in charge of their change. So I think it's very, very refreshing. And I've said this in numerous times I've talked about motivation interviewing, is that if I'd known that earlier in my career, I know that I would have been much more effective with the patients that I worked with. And I wished I would have come across this a little earlier in my career. But so what is motivation interviewing? So it's a strategy for engaging patients in making their lifestyle changes, making them their own, meaning that they have ownership of the change, and you act as a conduit or an encourager to get them to do that. And this can be used effectively in the self-management of diabetes. So you as a CHW, by practicing some of these tenets of motivation interviewing, or just maybe reading more about it. So that's what I encourage you all to do. After hearing this today, if you're very interested in learning more about motivation interviewing, there's a lot of training programs that are available for you to learn more about it, and I encourage you to do that. But you can have instant influence right now with your patients by practicing empathic listening, learning the art of reflection, and sort of meeting the patient where they are. That's one of the key tenets of motivation interviewing, is an instant influence, is meeting the patient where they're at. And so, and of course, many of the strategies discussed can be utilized without formal training. But if you'd like to be considered a motivational interviewing expert, you can actually, like I said a few seconds ago, you can actually take some training and learn that skill. So what is motivation interviewing? So the basic tenets of motivation interviewing include expressing empathy through reflective listening. So what is empathy? Empathy is the ability to understand and share the feelings of another. So it is not sympathy. Okay, it is putting yourself in that person's shoes and listening and hearing what they have to say from their perspective. So it's expressing empathy, and reflective listening is being able to actually take the time to listen to someone. See, typically in conversation, most of us are when we're listening to someone speak, oftentimes we're already kind of constructing what we're going to say back to them while they're talking. So we're not actually doing reflective listening. We're not actually doing attentive listening. And I know I'm terribly guilty of that. My wife tells me that all the time. So I know that I tend to do that. So reflective listening is attentively listening and then reflecting back to the patient or whoever you're communicating with what you thought that they said, the meaning and the intent of what the message was that person communicated to you. The second main tenet, is developing a discrepancy between the individual's goals and values in the future versus their current behavior. So the discrepancy that's important to motivational interviewing is getting your patient to see where they would like to be versus where they are now, and creating a discrepancy that motivates them to make movement toward that future goal or value. Okay, avoiding arguing and direct confrontations. In substance abuse treatment, which is basically where most of my clinical practice experience took place, there was a lot of confrontation. In the past clinical practice, it was common to confront patients on their addiction, confront patients on their denial. In motivational interviewing, you specifically avoid arguing and direct confrontation. So you meet the patient where they're at and let them move through the stages of change, which I'll talk about in just a few minutes. The fourth is adjusting to resistance rather than directly opposing it. So again, tagging on to the other one, avoiding arguing and direct confrontation, what you're going to do is adjust to the resistance rather than opposing it. And I'm going to tell a little story that was told to me, and it really kind of helped me frame my understanding of motivational interviewing. There was a patient who the care team got together, and the patient had diabetes and several other chronic conditions, and they were getting together to work with the patient to develop some dietary lifestyle plans for this patient, treatment plans for the patient. And the patient said, I'm all for that, but I'm not eating any vegetables. I hate them, don't like them, not touching them. And so in an older way, in the older paradigm of treatment or developing treatment plans, of course, the responses would have typically been, well, how come you don't like vegetables? There's got to be some that you would eat. Oh, my God, have you tried corn? Corn's really good. Or I like asparagus. That doesn't taste anything like a vegetable. On and on and on, with all these sort of resistance to the patient, meeting the patient where they're at. And so what the appropriate response and what the treatment team did was, is simply just say, okay, let's work with that. And they moved ahead and developed a lifestyle and dietary modification based upon the patient's preference of stating he didn't want to eat any vegetables, right? And I can relate to that because I don't like vegetables either. So that'd probably be me saying that. And I don't throw that story out because it's like me. It's just, it was a good example of applying some of these motivational interviewing tenets. And eventually what had happened with that is they got the patient to eat some vegetables. But he came to that on his own, without confrontation, without resistance, without, telling him, well, you got to do it. You can't have a healthy lifestyle. You don't eat vegetables. And eventually the patient did adopt some vegetables into his dietary plan. So again, adjusting to the resistance, meeting the patient where they're at. And oftentimes this can be a lengthy process, as we look at in the stages of change. A few slides ahead, that personal change, behavior change, is not a process that occurs overnight. It's a very lengthy process, and it can get kind of frustrating when you're working with patients when they don't make the movement that you'd like them to. And of course, our first line of defense is to confront them and say, well, why don't you try this? Why don't you try that? Why don't you try this? Why don't you try that? As opposed to just meeting where they're at and allowing them to make their own decisions and move forward. And the last is supporting self-efficacy and optimism, or developing autonomy. The idea that the patient is the person directing the change at their own pace, and they develop ownership, right, of their efforts at making changes. And the supporting self-efficacy is making the patient feel that the change comes from within themselves, not because of what you as the healthcare professional is doing to direct that or to push it. So they come to their own decisions and make the changes based upon where they're at. So the first tenet would be expressing empathy. And I know all you community health workers are well equipped in providing empathy and communication. You wouldn't be doing this line of work if you weren't good at that. And so, again, it's just the ability to share and understand the feelings of others and putting yourself in their shoes. By developing this understanding of someone else's challenges, barriers, and struggles, it can have a significant impact on your patient. I know in addiction treatment there has been this sort of, I don't think controversy, but a lot of patients like working with therapists who are in recovery themselves because they feel that therapist understands their position, their values, their role, what they have been through. And I'm not a believer that somebody who hasn't had a heart attack or depression or has made a suicide attempt cannot help somebody with those issues, okay? I'm a firm believer that the therapist or CHW skills lie within the person and their ability to connect with patients. But a lot of patients do feel that if you can understand where they're coming from, especially maybe if you've been there, that does sometimes create a bond that can help. And I know a lot of community health workers, from my experience in talking with them, do come from backgrounds where they've had experiences with some of the chronic conditions that their patients are experiencing or other concerns that their patients may have, socioeconomic concerns or lifestyle issues, that they can understand where the patient is coming from. So empathy does not include sympathy. So sympathy is when you show pity or sorrow for the patient. So it's important not to mix those messages. So empathy comes from understanding where they're coming from. And certainly you can have feelings of sympathy for a patient, but it's best to show empathy as opposed to sympathy. So some examples. Some examples of empathic communication would include stuff like, is it okay if we talk a little bit about your diet? Or do you mind if we discuss your plans for exercise? Or understanding that, and communicating to them that you understand that any kind of change is hard. And could we kind of talk together about how we may both help you do that? And another important concept is making them feel like they're not alone. So there are things I can do to help. You're not alone. We're in this together. I can help you through this. So as part of this, if you notice some of those examples, it sort of included asking permission to lead a discussion. And I think that's a really important part of motivational interviewing, is to ask permission. Is it okay if we talk about this? Is it okay if I bring this up? Is it okay if we do blank? Because what that does, it allows the patient to say no if they want to, okay? If again, an old style of counseling is you just charge right into the topic and didn't ask permission. So already you're leading the conversation down a path, and if the patient didn't want to talk about it, they're going to be less inclined to tell you no if you've already started down that road. So if you ask permission, it allows them to say no, and it also conveys respect and empathy to their situation. So what happens if they do say no? Well, you say thank you very much, and you move on to something else. Respect that no. You don't kind of slide around and say, well, how about if we did this instead? How about if we talked about this instead, or another part of this issue? No, if they say no, the no is a no, and you can move on. And again, sometimes that's frustrating because we have sometimes limited time with our patients, and we want to have an impact. So if they say no, so what do we do now? We've got to sit there going, okay, what do I do? And then you move on to something else, whatever that may be. Then developing discrepancy. So this is a key component of motivational interviewing too, because it allows the patient to experience the difference between where they are now, or the discrepancy of where they are now and where they might want to be, okay? So it allows the patient to view their current situation as unfavorable in some way, okay? Some can really see the totality of where they're at. They have diabetes and they're eating poorly. They don't check their blood sugar. They're not using their glucometer. They haven't had an A1C in a while. Whatever the behavior change may be. But this discrepancy allows them to begin to see their situation as unfavorable. And it's not by you telling them that it's unfavorable, it's allowing them to see it as unfavorable. And then promoting a positive outlook on future behavior change or where they would like to be. It also helps by allowing the patient to realize that that behavior change is possible, and it begins with them, that ownership of their change. So some examples, some phrases you can use. What are your concerns about making changes in whatever, diet, exercise plan, healthy eating, whatever it may be? That allows them, what are your concerns? Hearing it from them. Doing, attentive listening, putting yourself in their shoes to hear what their concerns are about making whatever change you're asking them to do. What are the cons and pros of beginning an exercise program? So I just threw exercise program up there as an example. The important thing here is beginning with the cons, because that helps create discrepancy. Most patients will be more than happy to tell you about I'm going to use smoking cessation, for example, what pleasure they get out of cigarette smoking or tobacco use. Sometimes the cons are a little harder to identify, and by identifying the cons first helps create that discrepancy, right? So they're seeing, well, I don't eat well, and I'm sluggish all the time, and I put on a lot of weight, and my family's always getting on me about eating better. I should eat better. So those are the cons. So what are the pros there? Well, I like to eat. I enjoy my food. They're really good at identifying those. Helping them identify the cons or leading them to identify those cons. Remember, if you want them to do it, helps create the discrepancy. So another example, what is your biggest fear about adopting a more healthy way of eating? Because oftentimes behavior change or resistance to behavior change is rooted in fear, right? The patient is afraid of losing something they already have, right? Control over their eating habits, pleasure from eating, as you eat, dietary changes as an example. It's harder for them to make that change because they fear losing something. So having them talk about those fears helps them, again, create that discrepancy. Where do you see yourself in 6 months, or where would you like to see yourself in 6 months? Is another way of having them think forward to say, well, I'd like to see myself, I'd like to lose 20 pounds, I'd like to eat a little better. It gets them thinking more about a future orientation. And what can I do to help you with your plans? Again, offering that support. Or would you like me to help you with those plans? Again, asking permission. So listen for change talk. Now, change talk is simply just those phrases a patient says to you that indicate their willingness to talk about making behavior changes or our willingness to make behavior changes. Important. And it's small things. And attentive, reflective listening will help you with hearing change talk. Avoiding arguments and adjusting to resistance. So, in motivation interviewing, we want to empower the patient to direct the change rather than you telling them where and how to begin. So again, some of those on the last slide we talked about, creating a discrepancy. So by creating the discrepancy, it sometimes allows you to have sort of an in to begin talking to the patient about directing them to empower them, directing them to make the change, to empower them to make that change. So rolling with resistance, you hear that phrase a lot in motivation that you're doing. So it means allowing the patient to express the full range of emotions related to making that behavior change or making any changes. Hostility, resistance, reluctance, without fear of rejection or attempt at redirection, okay? It's okay to let them go with what they, I hate this. My wife's always on me about stopping smoking. She's always on me about weight change. You guys, all you professionals, all you want to talk to me about is losing weight. I'm sick of hearing about it. It's all I get from my doctor, from you, from my wife, from my family. Let them share that and vent that. That's okay. That's rolling with the resistance. It allows them to get those feelings out, and you're not attempting to stop that, or attempting to rationalize those or to redirect the patient to more positive thinking, right? So you want to act as a supporter, not a persuader, and active confrontation is not recommended, as we know that, think about yourself. When somebody actively confronts you on a behavior, you're more likely to become defensive, and it only heightens your resistance. So try to avoid confrontation as much as possible. So some examples. I understand your concerns about weight loss. How can we move ahead taking those into consideration, right? So this might be, that's the example of the guy who didn't want to eat vegetables. I understand your concerns about not eating vegetables. How can we move ahead by taking that into consideration, right? I can see where you're coming from. Can we develop an eating plan that includes your preferences? I understand why you don't want to do that. No problem. Let's move on to something else. So that's if you get some resistance, because I'm just not ready to deal with that today, and I don't want to make any movement in that general direction, whether it be weight loss or whatever, healthy eating, seeing the doctor more regularly. It's okay. You meet the patient where they're at and say, okay, no problem. Let's talk about something else. Supporting self-efficacy. So self-efficacy is really, as the slide says, the glue that holds these concepts together and is at the heart of, as Elise talked about, diabetes personal action toward health workshops, which is self-management. So self-efficacy, the view that you can make the change, that you have the skills and the wherewithal to make behavior change. So it's good. We can help the patient along with that, being a supporter by illustrating areas of strength that the patient possesses. You can look at, have the patient describe times in the past where they've accomplished goals, no matter how inconsequential it might be to them. So it might be that, has there been any time when you've been able to lose a little weight? Has there been any time when you've been able to stop smoking? Have there been times when you've been able to eat a more healthy diet, whatever it may be? And sometimes they'll poo-poo that and say, well, yeah, but it was only for a day. I only did it for a week. I went to the gym because my wife asked me to go, and blah blah blah, and I didn't do it after that. Well, that's an accomplishment, right? You went, didn't you? You went to the gym for that week. Didn't matter how you got there, right? You did it. So, help them identify times when they've accomplished goals, and then praise them on that they were able to then achieve that small goal. So use praise and encouragement, and listen for change talk. So that's when they might say, yeah, you're right. I did go to the gym that week with my wife, and it wasn't all that bad, I guess. Some things I liked about it. I hated this machine, but I like walking on the treadmill. That was fun. They had a big TV up there. I could watch the NBC Evening News, and that was fun, So you could encourage them that, hey, you've done this. Let's, maybe we can try to do this again. And then along the patient to move through the changes at their own pace. Remember, it's self-efficacy. It's a long process sometimes, and the progress is sometimes slow, so you let the patient move through it at their own pace. So we've talked about the 5 principles of motivation interviewing. Just want to finish out with the stages of change. And this is what's called a trans-theoretical model, meaning Prochaska and DiClemente, they're the authors, the researchers, the academicians that came up with the stages of change theory. And what they did is they took a lot of theories of human behavior and change and developed them into this trans-theoretical model, which is the stages of change. And the stages of change include, I think, five different stages. So the first one is pre-contemplation, and this is where the person you're working with has no interest in change at this time, whatever that change you're asking or helping them make, right? They have absolutely no recognition of problems or consequences, right? So it's like, I'm perfectly fine. My diet's good. I don't have any problem with it. I like what I eat, and I'm going to eat what I eat, and that's it. So no contemplation at all. So that's or no contemplation of any problem or consequences. The next stage is contemplation, and this is when a person may be ready to make changes within the next 6 months. So in this stage of change, there is some recognition of problems and consequences, right? So they do maybe recognize that, yeah, I am gaining some weight, and yeah, I get heartburn a lot and all that. I don't eat good. I eat a lot of greasy foods, fried foods, and my heartburn's bothering me, and whatever else it may be. So they do recognize there are some problems, and there are some consequences from that. Maybe the doctor told them that their blood pressure is up and their A1C is up, and they start to recognize that maybe there's a connection here between my, what I'm currently doing and some of these things that are happening in my life. But they still may remain ambivalent. Again, the idea that, I can see this, I see the objective evidence, but I'm just not ready to change right now. So the preparation stage is where the patient makes small steps toward behavior change. And when I mean small, I mean they can be very small changes, right? They can be maybe, I'm not going to eat, I'm going to, instead of eating 2 bags of potato chips a week, I'm going to have 1 bag, or I'm going to cut down on my caffeinated beverages. I normally drink 2 Cokes a day. I'm only going to have 1 Coke a day. Things like that, small steps toward behavior change. And that's when they begin to believe in the preparation phase that they think that, or they start to believe that the change will result in improved health. I guess the third one on that, is after preparation. I thought there was a slide there, my mistake. The action phase is where the patient puts behavior change into action for at least 6 months. So that means they're going to the gym. They're shopping and adopting a healthy eating pattern. They've stopped smoking, if tobacco cessation is one of the goals. They've enrolled in a diabetes personal action toward health workshop. They've signed up for diabetes prevention program. They've done something of action that they're maintaining for at least 6 months. Okay, and that's considered the action phase. And then the final maintenance, this is where they keep the behavior change going for at least a year, okay? So they're maintaining gym membership and going on a regular basis. They're seeing their doctor on a regular basis. They know what their A1C level is. They're using their glucometer at home. They've adopted some of the changes they've picked up from the Diabetes Personal Action Toward Health workshop. Whatever the behavior change they're working toward, they've been able to maintain that. And the next slide shows another kind of view of this. Here's the stages of change visual map. So you can see the pre-contemplation, contemplation, determination, action, relapse can occur in there too between action and maintenance, and even after maintenance too, patients can go back to their old behavior, okay? That can happen. They can start smoking again. They can quit going to the gym. They can stop planning their meals and going back to eating a lot of carry-out food or going back to their old dietary habits. So that can happen. So relapse is a part of this, and the patient can enter and exit at any stage in the stages of change. And you got to remember, the stages of change, it's not, as the circle shows here, it is not a linear progression, meaning that patients don't go from one stage to another, to another, to another. There are a few that do that. Most patients will vacillate between contemplation and action. Go back to contemplation again, maybe go up to maintenance for a while, drop back to action, drop back to contemplation again. There's a lot of ways they can jump in and out of this circle because behavior change is hard. It's hard to maintain major lifestyle changes on a long-term basis. It is really difficult, and there's oftentimes a relapse in that. So when you do have patients who quote-unquote relapse, and I'm not talking a relapse on substance use or anything like that, but it could be if that's the behavior change you're working with them on, it's okay. It's okay. Again, no shame, no confrontation on that. Why'd you do this? Why did this happen? It's okay to talk about it, but, is it okay if we talk about why you think this didn't work this time? What were the things that worked? What were the things that didn't? And use some of those motivational interviewing strategies to help you get the patient back on track. So, again, stages of change, this sometimes can be a very long process. And think of yourself when you've had any behavior changes that you've made, how difficult that was at times to adopt those changes that you've elected to make. And that's pretty much all we have here today. I think we have a few minutes for some questions, but Michois certified CHWs who attend the webinar will receive a CE toward their 20 required CEs. And what I'm going to do is submit the attendance sheet to Priscilla, and she will mail the certificates out to all you guys at your given email address. So if there are some of you who listened together in a room, just contact Priscilla. Let her know that was the question, that you attended the webinar, and you were in a room with other people, and she'll send you the certificate as well. What we'd like to do now is there's our contact information, both of Lisa and myself. And what we'd like to do now is bring up some polling questions in just a second. We got those up there now. If you could take a minute to take our satisfaction poll and evaluation poll, we greatly appreciate that because it helps us see how Lisa and I did. We take your feedback very seriously, and we'd like to hear your feedback on how we did.
And then also we're going to include the slides in the chat box. So we're logging in right now to make sure that you guys can have access to the slides. And operator, can you open the line for questions at this time?
Sure. Ladies and gentlemen, at this time, if you would like to ask a question, please press the number 1 key on your telephone keypad. If you would like to ask a question at this time, please press the number 1 key on your telephone keypad. Our first question will be coming from Judy Keetry. Please go ahead.
Oh, I'm sorry, I don't have a question at this time.
Okay, no problem. Alrighty, our next question is coming from Gloria. Please go ahead.
Can you tell me again where you said you would have the this presentation?
We're going to include the link to the slides in the chat box in just a minute.
Okay, thank you.
Yep.
Again, ladies and gentlemen, if you would like to ask a question, please press the number 1 key on your telephone keypad. Our next question is coming from Octavia Smith. Please go ahead.
Hi, Octavia.
Good morning. I was trying to see the poll. I don't see the poll. Or is it not up yet?
Oh, it should be. We're seeing it.
I see the contact information up, and that's all.
So if you look on the right-hand side of your screen, there should be a little drop-down for polling. If you open that, you will see the polling question.
Yeah, I should have said that. My fault. Yeah, so those of you that, if it's not showing up on your screen, at the top on the right, it says polling.
Gotcha.
And just click on that. Yep,
I see it. Thank you.
Thank you. You're very welcome.
Our next question is coming from Valencia Dixon. Please go ahead.
Yes, my question is, I'm on the phone conference. Is there a way that you can send us the poll via email or the different links?
Oh, that's okay. If you can't get the poll up, that's fine. Don't worry about it. You're fine.
Okay, and I don't see your personal email either.
It should be on the last slide there.
I'm not looking at the video. I'm on the phone conference.
Oh, it's MLOUSH at mpro.org.
You said
MLOUSH at mpro.org.
Okay, thank you.
You're very welcome. Any other questions?
And just to let everybody know, the link is not working in the chat box right now, so what we will do is just email the link to the slides to everyone who's attended. So you will get that in your email that you've registered with.
We do have a question coming from Jill Stark. Please go ahead.
Well, that was my question. I can see the poll, but I can't answer the question, so. Wherever I'm clicking, it's not accepting it.
Oh, I am so sorry about that. Don't worry about it, Jill. We use these just for kind of our own purposes to see how we did, so it's not life or death if
Okay.
But thanks for trying anyway. Appreciate it.
Sure.
Again, ladies and gentlemen, if you would like to ask a question, please press the number 1 key on your telephone keypad. Again, if you would like to ask a question, please press the number 1 key.
Okay, Jeff has just posted the link to the slides in the chat box. So take a look at the chat box, open up your chat if you don't have it open, and you will see the link at the bottom to the slide. And we thank you all for being a part of our webinar today. Thank you to Priscilla Holman at Mishwa for asking us to present on this topic, and thank you to Elise DeYoung. Thank you to Jessica Allison for technical assistance, and
thank you, Mark.
And thank you. We appreciate you all being here. If there are no more questions, we can close the webinar.
Thank you, everyone.